All right, hey guys, it's Monday, 12 p.m. Central Time. So we go live every Monday at 12 p.m. Answer all questions related to lipedema. Our before and after today is we have on table and 1 month out. This way you guys can see how do patients look on table and how do they look standing up a month out after surgery. So what I'm gonna write here is to kind of write your questions below, and we will get started. Write your questions here. That's awesome. Okay, so let's do that here. See familiar faces, and we'll get going. All right, so our patient here, she came to us, as you can see, stage 1. For most patients, or for most people, when they look at her, they think she just have normal legs, and they say, you know, how come like she doesn't need anything, her legs look great and all that stuff. But the patient was having pain. She's a typical stage 1 patient where the symptoms are worse than the appearance. And then when you go to like stage 4, then you have the symptoms are worse and the appearance is much worse. So when we look kind of close at her, you see this is the cuffing. That's kind of normal here, and that's kind of where the cuffing starts on her at that level. Normally we wouldn't have that. Maybe it's hard for you guys to see, but there's a fat pad that sits here above that ankle. And this is kind of fat pad here, fullness on that inner knee, we see that all the time. And that's again, stage 1. Pain, tenderness, easy bruising, heaviness, swelling at the end of the day. These are typical presentation. Varicose veins, especially on the back and over the calf area, we see that all the time. Sometimes patients with lipedema, they have hypermobile joint, kind of that very flexible. We've seen that in lipedema patients because it's a collagen storage disease as well as lipedema fat storage disease. So it's a collagen problem and lipedema fat storage, kind of combination of those. So we see other elements in patients with lipedema, autoimmune diseases, thyroid issues, veins, all the stuff that kind of, it's like more or less, it's like a package where lipedema is presenting, along with what we see and what we do is LippyLipo for lipedema. So kind of, this is her, we've done her front and back, and you can see 360 to the knees, calves and ankle, and as you can see, I mean, she looks perfect, right? I mean, perfect knees, perfect calf, goes all the way down to the ankle, and kind of like, she looked great before, but now she even looks better without the symptoms of lipedema. Because when she came back about a month later, she was like, oh my God, like I feel lighter, I'm more active, even though my husband like was telling me like I used at the end of the day, she used to kind of like stretch her legs, kind of like standing at the counter on the kitchen at the island, just kind of try to stretch the calf muscle because she's like been tender from the lipedema. Even a month out, her husband was like, you're not doing that. And she's like, oh my God, I never realized. And that's kind of like the functional improvement that we see with lipedema patients after getting LippyLipo. I'm gonna scroll a little bit here, just kind of show you like her afters at around like 1 month out. And this is her here. And kind of we're staying here on the front and then we'll go to the back. But you can see like at 1 month, and normally we have like huge swelling at that point, but look how awesome she's looking just at 1 month. This is her before, this is her here. We get asked a lot, like, you know, how we see patients on table, they look great, but how do they look like a month, 2 months, 3 months, 1 year after that? This is her month out. And if you want to see like multiple before and after standing up, go to our highlights. We have the before and after in highlights. You can see like long-term results from patients, sent from patients to us standing up, just kind of get an idea of how awesome our patients are looking. That being said, not every patient looks that good at 1 month. What I mean by that is some people, they swell like crazy the first 2 weeks afterwards, and then they peak around 2 to 3 weeks, and then it starts going down. So at 1 month, they might be bruised, swollen, all that stuff. We've noticed that patients stage 1, stage 2, they tend to bruise less. Patients without massive weight loss, tight skin, they tend to swell less than somebody massive weight loss. Around stage 3, there's more swelling that we've seen than patients kind of like her, where she's starting with a stage 1 she's in her early 40s, stage 1, tight skin, there is swelling, not much swelling. Now let's say somebody who's stage 3, they're 50s to 60s, little bit of weight fluctuation. What's going to happen, they're going to have more swelling at 1 month than the patient over here has. Let me show you another one here. This is kind of like standing up on the back on her at 1 month. It's kind of like you can see as well, like look how awesome. Like that looks normal. The only way you can tell she had anything done is by kind of, you see kind of the entry side of the cannula. Kind of one here, one here, one here, kind of this stuff. But and that's at 1 month. At 1 year, most of them, they kind of fade away. And this is heard before. Like it's impressive. Even though again, she looks great here, but when you compare from this side to that side, it's like awesome. Again, only 1 month afterwards. Now the question is, let's go back to the kind of like on table here. And then we go on table kind of showing the, let's go on table showing the fronts. The question is, how much fat do you normally take out? That's a perfect example. On her, we took 1.6 liters out. Imagine if we go in and we take 5 liters out on her. It will be a disaster because the skin's gonna look bad. It's gonna look like skin graft. It's gonna look mottling, discoloration of the skin. I mean, it's not gonna look good. And that's where the expertise come in play. You really wanna hit it. So this is key. Like that's what patients are now understanding more and more about. So basically, you have like a bell-shaped curve. Okay, so it's like that. You know. On her, that was like the ideal position. This is where we needed to be, the 1.6 to get her from here to here, okay? Let's say we push the lipo and we got 5 liters out. She would have like contour irregularities, she would have mottling, she would look bad. If we underdo it, if we stop the lipo around 1 liter over here, then she will have residual lipedema cells. So the expertise and the key is to keep pushing as much as possible to hit the peak and not pushing beyond the peak. You push beyond the peak, you get the side effects. Irregularities, contour, all that stuff. You stop below the peak, you'll have residual disease. And that's where really spending the time, like on these cases, we spend like 4 to 6 hours just sculpting. Micro cannula, take the time, do like amazing work, and that's like we're consistent every time. It's exactly like the same. I mean, we just spend all the time in that. But that's where you want to be. We never want to push the surgeon to go all the way here. If somebody is new and they don't know much what they're doing or kind of like not lipedema expert, these are the people who do over resection and end up with really bad outcomes. Or for people who are scared, kind of also starting, they don't know the anatomy very well, they're afraid to go below the knees, and they're kind of like starting into it, they're more likely to leave residual fat that potentially we call overgrowth or recurrence and all that stuff. I think if the surgery is well done and we do a great job, do great outcome, the chances of that should be less than 1%. I don't think any practice should have a more than 1% chances of recurrence. Again, we can say that because we've done hundreds and hundreds of these and we just don't see it. So we won't see it in the books yet, but I think that's all what we do. So we kind of know where the numbers need to be on those cases. So I feel pretty good about kind of the percentage of recurrence on patients. And we used to say we don't know, maybe 5% or less, but now we've done so many and really we just don't see it. So I would say less than 1%. If somebody is having higher percentage, especially if you're the surgeon here listening to that, make sure you're doing a good job on the resections, on the liposuction side. But don't overdo it because you'll have side effects. You gotta really hit it here. If you're having a high percentage of overgrowth, you're probably in that area here. So you gotta kind of see like where it is and where you need to go. All right. Another question we have here is on the veins. Kind of like what happens to the veins with LippyLipo. The issues with the veins is it depends on the problem that's causing the veins. If the problem is a vein problem, then LippyLipo is not going to help much, maybe a little bit. If the vein is from the lipedema fat, pushing on the veins and preventing blood return to the heart, when you take those lipedema fat cells out, the venous outflow is better, and then the veins get better. So, depending on the cause of the veins, in our experience, most patients, their veins get better. They don't totally improve 100%, but we've seen anywhere between 50 to 70% improvement on the veins. So when I tell patients, like, don't do your veins first, do your LippyLipo first. Because the chances of needing a vein treatment is much less if you do it after the fact. Very rarely, in very rare occasion, we've had patients go get their veins treated first and then we did on that. I actually don't think about anyone we've done vein treatment on first and then we move them to LippyLipo. Most patients we just do LippyLipo on them. So that's a very, very common question that we get asked on the veins. Another thing that we get asked is compression. So sometimes patients, they do multiple consultation and then they get told multiple things. So if you really, think about it and spend the time of thinking about it, what compression does is, it after the procedure, we're talking after LippyLipo, when you take the fat out, now there is a dead space between the muscle and the skin, because it used to be filled with lipedema fat cells. Now we don't have those lipedema fat cells. So since there is a dead space or empty space, now the skin has ways to move around and heal in an abnormal position and that. So you want to have a good compression where it keeps the skin attached to the underlying structure without much movement. If you don't have that, too much movement skin over the muscle can create few things. It can create a fluid collection or a seroma. Fluid buildup in that area over time can cause fibrosis or scar tissue. Not compressing the skin down can lead to excessive swelling. Also, if the skin is not it's like a baby, you want to wrap them well, you want to just put it where it needs to be. If the skin is doing whatever it wants to do and the muscle is doing whatever it wants to do, what happens is the nerves are being irritated every time that it's that moving, so it's more tender to the patient. So you want to make sure you are compressing well. You keep the compression for as long as you can, at least 3 months, at least, whether early stages or late stages. Sometimes patients are being told, just 4 weeks, some of them 2 weeks, 4 weeks, 6 weeks, it doesn't matter. It actually matters. It matters a lot. It matters from how long the swelling is gonna be. Sometimes it matters from a experience. Can patients feel better with the compression because the nerves are not being irritated? Less bruising because it's keep compressing those small venules so they don't leak. Because if you take the compression out, now that small vein, it oozes some blood, and that blood causes bruising on the long term, and bruising can cause discoloration on the skin. So all these stuff can be all prevented or minimized with good compression. And you want to use a compression that it's that's user-friendly. Some of them are not, some of them are better, depending on what compression is being used. So you gotta spend the time and really do it. The longer you do it, the longer you wear it, the better it is. When to stop it? Whenever you feel the swelling is gone. Really. Can you stop it at 3 months? You can. Would it be better to wear it 6 months? Absolutely. Would it be better to wear it 1 year? Absolutely. And even myself, I went through that range. When I first started, I was like, maybe 6 to 8 weeks should be enough. Now, it is enough for regular liposuction. When you go to lipedema and you go doing ankle lipo all the way down below the knees, the amount of swelling is much higher than doing just a regular stomach liposuction. It's a different ballgame. Here, you can do 4 to 6 weeks compression. In that area, you need much longer to have long-term results, good results. But the other thing on compression, you always want to compress one area lower than the area that was liposuctioned. So it doesn't create a contour irregularity or a cut-off sign or the kind of a step off. What I mean by that is, let's say we did liposuction all the way down to the ankle, okay? And we put compression, a regular compression, that goes down to like here. What happens since there is compression here and no compression here, that area is gonna swell significantly. And now the patient, they will have a step off deformity. Even though the liposuction was done well, and you look at the end of the case, like nice and smooth, you put that compression on, it's gonna compress the fat above, move fat below, and then you're gonna have a contour irregularities there. So it's very important, the compression, to kind of start from the foot, below the ankle, below the area that was liposuctioned, and then push the swelling all the way up. So you always wanna go one anatomical landmark below the area that was liposuction. No different than the arms. Like if you do like liposuction down to the forearm, you want a compression that goes from the wrist all the way up. You don't want a compression that ends up here, because now there's going to be residual fluid here, residual swelling that will ultimately lead to fibrosis or scar tissue. So that's crucial. I see a question here from Helen. Do you need the patient to use compression before surgery? Great question. The answer is yes. You want to use it before and you want to use it after. Now, after is more important than before. If you have to choose between the two, after. But if you want the best possible, use it before. Because when you use it before, you're already minimizing the swelling and the tissue. So when we're doing our LippyLipo, you have less swelling in that area. So it helps you, and it helps the lymphatics, it helps keep things open by using it before. So in a way, you're like preparing for the marathon, right? You're preconditioning the veins, the lymphatics from beforehand until afterwards. And that's kind of same too for MLD. Some people ask, shall I do MLD before or after? Definitely after. But if you do it before, it's also helpful. First, you get to know your therapist. And some therapists are better than others. You want to make sure you have a good therapist who knows how lipedema is, how lipedema functions. And I know you have multiple questions, but let me kind of like a big tangent here on therapists. And some therapists are amazing and they do like great job. They work the patients afterwards and that. But I've seen some therapists where they might complicate things for patients, and you gotta be careful. So where you have, if a therapist is not very familiar with lipedema, they might be doing what they normally do for regular liposuction, and then they reach a point which is like normal lipedema fat cells, right? Kind of that, and be like, oh my God, I feel like it's hard in here, or it's kind of like, no, maybe that's blood clot, right? So now the patient's like, oh my God, I'm having blood clot, and the therapist, she has no idea, right? She hasn't done much lipedema. And now the patient anxiety goes up. Now she's worried she has a blood clot, and all what she has is just like normal post-operative swelling from lipedema. But the problem is when that happens, the cortisol level goes up in the patient, their immune system goes down, they are more prone for infections and problems and issues and psychologically, and they're not happy and they go through a bad cycle. So all this could have been prevented by going to a therapist who know what they're doing. They've treated lipedema. And sometimes like they take pictures, they send it to us, and they're like freaking out, which they should if somebody's having, like feeling this way. And then we look at it, it's like, this is normal. I'm like, okay, Jerry, let's put the therapist on the phone. It's like, for that patient, you massage, and then this is just like normal post-operative healing. And we educate the therapist, and it's like, hey, listen, first, we haven't had any blood clots ever because it's done awake, so we've been like very lucky, right? Second is you gotta make sure that you educate the therapist and the therapist know what they're doing, because by them transmitting their suspicion of something that doesn't exist, it's actually hurting the patient, right? So we've seen it a few times now where we're kind of like, we spend more time educating the patient and educating the therapist. And now we've seen it it's flipping. Patients will be like, oh, I'm actually swelling on both sides and feel the same on both sides. I'm good. I know the therapist said that, but I was like, good, great. So like, you want to know like, what's that? And again, within that early stages of treating lipedema, where it's very known from a therapist, dietitian, GYN, endocrinologist, the entire medical field don't know much about lipedema. So I found now that patients actually know more than physicians or other therapists in the medical field. So we actually, by doing these lives, were able to educate patients more on it. And sometimes I've seen a lot of physicians, even though they might not be live on with us, they watch it and then they reach back out to me and ask me certain questions. So that's been helpful of educating other healthcare professionals on it, so that if they are doing it, they know what to expect and kind of what's that. Let's keep on going. So Helen is saying, how long before? The longer the better, but at least you want to wear it 6 to 8 weeks before. But sometimes some lipedema patients, they are on lifelong compression anyway, especially if you're stage 3, stage 4, you're going to be on compression for a long time. Stage 1, she might be intermittently, if she's flying, if she's in a car, if she's standing up, if she's like in a conference and stuff like that, then she's going to be wearing more compression than not. But the more you wear it, the more you precondition yourself. And another question, how long after you give birth do you have to wait to get surgery? Great weeks. The typical teaching is you want to wait at least 6 months, 6 months to a year. Ideally a year, 6 months is at least. And part of the reason is hormonal changes. There's a lot that goes on after giving birth. You know, the hormones, the getting psychological impact, all that stuff. So ideally you want to be at least 6 months to a year after giving kids to do that. Now, that being said, I tell people, if you can do it before pregnancy, it's better, because with pregnancy, we know it gets worse. But if it happens, you get pregnant, it is what it is, then you want to wait 6 months to a year afterwards. Same goes for menopause. If you're kind of within that like 40 to 50 range, perimenopausal, do it. What's going to happen when you're like 50, 52, 55, and you get there, your symptoms are going to worsen. The lipedema fats are going to worsen. You might need more stages, more sessions, and the skin will not redrape like it would redrape before menopause. So these are key things to think about. The other thing that now we've been hitting it hard here on our lives is hormonal replacement therapy, HRT, OCP, testosterone, pros, cons, what's ultimate estrogen level should be. And these are very important, because now we know that estrogen is good, but too much estrogen is bad. Too little estrogen is bad. You gotta make sure about that. Same here. Too much lipo is bad, too little lipo is bad. You gotta hit it really well. Same with estrogen, same with hormonal replacement. Pretty much same thing in anything in life. Balance is key. You gotta see what that balance is to be able to provide the most outcome possible. Good question here, Helen. So I'm gonna keep on scrolling down. There's few people trying to join the live. I usually don't allow it unless I have somebody who I've spoken to before to get them on. That being said, if somebody is in the healthcare system who knows about lipedema, if you're a physical therapist, dietitian, somebody who does a lot of volume related to lipedema, reach out to me. I'm happy to go on a live and kind of share your expertise with our patients, and hopefully I can learn from you as well. Coastal is saying, how young can a patient be? Usually I like them to be of age, kind of 18 years and older, so that they're making their own decisions. We know that the hormones have stabilized, they are beyond puberty, but that's kind of, most of our patients are between that 18 to like 70-year-old, within that range. But the majority, I would say, we see them as like that 30 to 60-year-old range. Very few in their 20s, very few in their 70s, but the majorities are like 30 to 60. And that's kind of like our population. Janine is saying, I'm 60, 4 surgeries, stage 3, 4 weeks post-op, posteriors, feel I'll be in compression for life, hopefully a lighter grade though. Absolutely, I mean, stage 3, from a compression, and you're 60, from a compression standpoint, I tell patients, depending on your stage and kind of looking at all our patients kind of like overall, there's 10 to 20% they will need compression for life. And those patients are 50s, 60s, 70s and older, stage 3, 4. They tend to need it for life. Then you have patients like our patient here, stage 1, younger, then she might need it 6 months to a year, plus or minus. And then you have about patients kind of who are in between, they would need it intermittently. What I mean by that is they would need it on certain occasions. Let's say they're flying for like 20 hours, right? Or they're working, they're doctors or nurses, or like, you know, they're whatever they're doing, they stand on their feet for a long period of time, then they would need it for that, for those events. So depending on where they are, at least in your case, at least a year, and then you're gonna see. So my advice to you is definitely do for 1 year, and then once you hit the 1 year, test it, right? It's your body. You can test it at that point, and then you see. If you take them off and you say, oh my God, by the end of the day they're swollen, guess what? That's the answer. You gotta keep on wearing them. But if at 1 year you take them off and then you're like, you know what? They're not swelling at all. I feel great. I'm good. Then maybe you don't need them. Or it might be intermittently. So there's no like 100% this way or 100% that way. It depends on the patient. Like no different than here. Maybe at 1 year at this patient, maybe at some point she might swell certain times. And then she might need to PRN needed. So you gotta see where your body needs, what's that balance to your body, and kind of adjust accordingly. But that's awesome. Congratulations. I'm glad you did it, and that's great. And you're 60, and that's the thing. When you're 60, you have a window. So you want to treat those early on. Like you want to, because if you don't do anything, you're stage 3, most likely, chances are, over time, it's going to progress stage 3, stage 4, knee problems, knee issues, knee replacement, all that stuff. And then you reach a point you might not be able to walk. So you have that window where you're able to get it done and you're still younger and healthier, so that you minimize the chances of that happening. So congratulations, that's awesome. The lipedema girl, she's saying, when you operate, is there any special care taken not to hit damage certain veins? Some of us have pronounced veins that already hurt. Can those be avoided? Great question. So we talked a little bit about the veins, and I'm gonna kind of like answer your specific questions, like how can you minimize injury to those superficial veins that are there? The way to this, you cannot like 100% avoid it. You know, sometimes you do go through those varicose veins because they are in the same plane where the fat, where the lipedema fat is. So you have the muscle here and have the skin here, and then in between the two you have the lipedema fat cells, you have regular fat cells, and you have another layer that separates the superficial layer of fat from the deep layer of the fat. And that's where those veins live. They live in the deep layer and the superficial layers. In lipedema patients, they have wider veins, wider varicose veins than non-lipedema patients. When you do the lipedema treatment, you take the compression of those veins, and then the veins tend to work better. Now that being said, every now and then, as you're doing the lipo, because those veins are so fragile, when you, especially with lipedema patients, sometimes you get like bruises and you have no idea what happened. You're like, oh my God, I have like a large bruise here. Where did that come from? Because patients with lipedema, they have weak walls. The walls of their veins are weak because of a collagen problem. So any trauma to the area, it damages the wall, and then the kind of the blood leaks to the veins. So sometimes we see that in patients with lipedema, but sometimes we do like 5 liters with patients with tons of veins, stage 4, and you get like literally no blood in that canister. So it's a hit or miss. But the key to minimize injury to those veins is the technique is doing very well tumescent, so that you separate the area, inflate it, go through the cannula, and suck as many out as possible with minimizing injury to the wall of those veins. And that's very important. So to answer your question, can it be 100% avoided? No. Can you limit the risk? Yes. But let's say it happened. Let's say the cannula, it hit that vein, right? What's going to happen is during surgery, you see kind of like, you see it coming out through the hole where the cannula is going on. So all what you do is just you hold pressure on it. No different than a kid having a small like laceration. You just kind of like hold pressure on it, and then the body kind of like will stop it. So what I normally do if I had those, I just hold pressure on it, I go to another area, I do the other area, and then I come back to that area. Now very rarely where we have that, and then you say, okay, I'm going to leave this area for the other session. But that's another option. If that happens, what you don't want to do, what you never want to do is, and I'm talking to you, I'm actually talking to your surgeon, or if there is a surgeon watching here, is if you get that and you continue liposuction, what's going to happen is you're sucking out blood, and now the vein is leaking more blood into, because like it's a pond now, right? Because you take it out, now it's gonna ooze more blood, and then you're gonna suck it out, and it's gonna ooze more, and these are the people who end up with being transfused. So you want to like minimize that. So if you have that, you just want to tampon at it, stop it, go to another area, and then come back to this area. And if you come back to this area still doing the same, you gotta wait and then treat it on the second session. We rarely have that. Every now and then we'll get it. I tampon at it, go to the other place, and then when I come back, it's usually no problem. But there's always a chance, and when that happens, I always tell the patient, hey, because patients are awake, so I'm like, hey, listen, there's a vein here not behaving well, we're gonna put pressure on it, I'm gonna go to the other side, then come back. If I come back and it's still not misbehaving, I'm not gonna treat this area, I'm gonna treat it on your second session. That being said, we haven't had to do that yet, but I'm sure we do many patients. I'm sure that's gonna happen at some point. But it's not a big deal. You're just gonna, the big deal is if we continue to lipo into an area that is oozing, that's a problem. You know, you just, whenever you hit like a drop of blood and that canister coming back, you want to stop that area, go to another area, retumescence this area, add some epinephrine, vasoconstrict it, and kind of improve it. I think this session has been great for physicians. So if you're a physician, if you're getting it done, make sure your physician comes to this live and watch that, because I think that's going to help them a lot. A lot of questions here are more about technicality of surgeries, and that's been very helpful. The lipedema girl is saying, right, I bruise a lot. Absolutely. I mean, that's lipedema. We see that a lot because it's a collagen. It's collagen storage. I mean, it's a collagen defect. Lipedema, it affects the lipedema process, but also the problem in capillary walls, all that stuff. So Laura is saying, how do you determine whether or not you are a candidate for surgery? It's actually simple. First, you look at the legs. By just looking at the legs, most of the diagnoses are done visual. It's clinical diagnosis. Tree trunk appearance, all that stuff. When you see it, it's that. Then, if you're still not sure, you look at the symptoms. Pain to touch. If somebody grabbing you, this, that, a pet, a husband, wife, somebody's like, get pain. Symptoms of lipedema. Easy bruising, heaviness, swelling, tiredness. All this stuff, kind of like you see them with lipedema. Patients with lipedema, when they hear those, they're like, oh my God, I have that. You might not have all of them, but you would have at least half of them. And that's pretty much getting the shape, getting that. Now, on the shape, not everybody goes down to the ankle. Sometimes the lipedema stops at the knees. So you can still have lipedema with having normal ankles. So some people say, you know what, my ankles are normal, but I have everything else. I'm like, okay, send me your pictures. I take a look. Actually, you have it on the inner knees all the way up, and most of them, they have it on that kind of like the tire, kind of the upper buttock area, love handle area. It's there. So they would have like a type 1, 2, 3. I mean, type 1, 2, 3 if it goes all the way down, and then different stages. So they would still have it, even though your ankle is normal, you can still have lipedema. Very good here. Keep going here on those questions. Candidate for surgery. Okay, so these are the questions here. Another thing that so we talked about the compression, we talked about the post-op. Another common question is, when can I go back to exercise, workout, like when, at what point? Now, and let's talk about after LippyLipo. Now, if you're getting it done under the general anesthesia or different techniques or different type, that's probably totally different recovery. Our recoveries from LippyLipo are very, very fast. Patients immediately after the surgery, they're walking out. Not on a wheelchair, they're not in a hospital, they're good. They're just like, they stand up, they put their clothes on, they put their back on, whatever they have, and then they literally walk out from the operating room to their car. So it's a very fast recovery, or fast kind of to go back. Now, is it, in terms of swelling and bruising, it's still better than general anesthesia, but it's not like, it's not like you're gonna stay like that for like throughout your recovery. You're gonna swell, you're gonna bruise, okay? And then it's gonna peak around 2 weeks, 3 weeks, and then it starts going down after that, depending on the body. In terms of like exercise, heavy lifting, yoga, all that stuff, I tell patients about 4 weeks, plus or minus. Your body is gonna tell you, if you're like at 4 weeks and you're like feeling great and that's it. I mean, you just go back to normal life. If you're like at 2-3 weeks and you're like not feeling yourself, don't push it. take it easy, enjoy it and that. My experience is at 4 weeks, most people are doing very well. At 2 weeks, most people, they need a little bit more time. Kind of like that. The first few days, patients are like, oh, that's not bad, because they're still kind of like, and that euphoric effect, they're gone off the lipedema, the area is still numb and that. And then after 3, 4, 5 days, they're kind of like, they kind of dip down, and then they keep on going down until that first week, second week, and then they kind of plateau around that. And then after the second week, they kind of turn the corner, and then they start kind of climbing back up. And then at 4 weeks, they're like, 6, 7, 8 weeks, and then they kind of go back on that good phase. And we see that over and over and over again with our lipedema patients. Very good. Vivi is asking, can this be done to the glutes? I guess what we mean by that is kind of to the upper buttock area. Most patients, we don't have it here. I wish we do have a buttock one. Patients with lipedema, they have it in the upper buttock area. So the short answer is yes, we do liposuction to the upper buttock, because lipedema, that tire, it sits on the lower back and that upper buttock. And most patients, they kind of like grab it and like, oh my God, like I feel it. It's usually above the hip dip on the sides. So on the side, you see kind of you have hip dip, saddlebag, but above it, you have that fullness. That's lipedema. And the key there is to do 360 lipo. So you narrow the lower back as much as possible and you transition to the buttock. So you get a nice hourglass shape. Otherwise, the buttock is going to be wider. Most lipedema patients, especially stage 3 and 4, the upper buttock area is wider than the lower buttock area. So the butt kind of looks like a V-shaped or square, kind of the same width, upper and lower. It's kind of like the same width. It should be the other way around. You should narrow at the waist and then go to the buttock and then you go down to the thighs. So you got to reverse that ratio going from the lower back to the buttock. Most patients don't know that. They think that's how they're built, that's their hip bone, or kind of like, but it's different. And over time, as lipedema progresses and as we lose normal fat, they lose fat from the regular fat, buttock fat, but the lipedema gets wider. It puts pressure on the buttock, and then they get like buttock collapse and widening of the upper part of the buttock. And that causes like bulging out in clothing. So the treatment there is to reverse the process. Liposuction the upper buttock area, liposuction the lower back, narrow the waist as much as possible. You gotta really narrow the waist. That's the key. Like narrow the waist and that upper buttock. Remove all the love handles, all that extra stuff that bulges out, and then transition to the buttock area. You don't want to liposuction the actual where the butt is, because if you liposuction that, it deflates and it causes buttock collapse. So you want to liposuction everything around it and leave the buttock, kind of the good shape of the buttock. We used to do tons of these, patients with lipedema and without, but since we shifted mainly to lipedema, most patients, I mean, we've been like fully booked with lower legs. I mean, that's kind of that, but we love it. The key with those is really the buttock. It takes a good expertise there. Exfa is saying, please let us know where you're based. With 1 hour north of Nashville Airport. Lovewell is asking, will you operate on a 70-year-old woman who is otherwise in good shape, good weight, no metabolic issues? Absolutely. We've done patients, I think we've done somebody from New York City, I think she was 76, 78, something like that. But excellent shape, health, runs New York Marathon. I mean, she's like, talk to her, she looks like in her 50s, really, but she was like late 70s. The key is not the age, really, it's about how healthy the patient is. And really with healthy, it's mainly the heart and the lungs because of the fluid that we inject. You want to make sure when we inject that fluid and we're doing the lipo, the heart is able to compensate for that extra volume, right? If somebody has a weak heart or they have like other comorbidities, when you inject that fluid, patients get like rhythm problems, irregularities, and it's just kind of like not safe. So that's kind of the limitation. So when you hit like, you said here you're 70, so you're like, probably you're at that window. When you go later, you're kind of like going down that slope there, and becomes much harder to get what the risk of it becomes more than the benefit. So I think in your condition, based on what you're saying here, I think you're the candidate. Laura is saying, what state do you practice in? Within Bowling Green, Kentucky, like at the border between Kentucky and Tennessee. But patients, they fly to Nashville Airport and they drive 1 hour north to our location here. I actually live in Nashville and I drive here to this location. What happened is when I started in this location many years ago. So kind of like we have all the setup, we have the certified operating room, my staff is here, everything is here, and kind of like I'm so like micro involved in everything, kind of like I want to make sure everything is perfect. So it's been like, that's how we had it and we like it this way. Madrid is saying, what could you do for flabby thighs? Well, it depends. If the flabbiness is from lipedema, then you need LippyLipo. If the flabbiness is you had massive weight loss and now you have extra skin, then you need a thigh lift, skin resection. Some people have both. They have lipedema causing that and they have extra skin. You treat your lipedema first, you get rid of the lipedema, get a great infrastructure, and then you tighten the skin over that new kind of like infrastructure. Sorry guys, I'm losing my voice here, but good questions. USA, Claudia, saying, can lipedema cause a lot of leg cramps in the lower legs? Will liposuction also help with that? You know, that's a great point. It's interesting you ask this question because I have many patients who report leg cramps with lipedema. So could it be the lipedema is causing that? Could it be it's part of the package that comes with lipedema that people are getting leg cramp? Very hard to tell. Could it be the heaviness of the lipedema fat pushing on the muscle, resulting on the leg cramp? Sometimes we see that, especially when you inject fluid in the patient, they say, I feel like the muscle is like cramping, and I believe them. Sometimes it twitches. And I think probably because of the heaviness of the lipedema fat on the muscle. So if I had to guess, there's no data, non-scientific, just my opinion, my answer would be probably yes. It can be causing that. I tell people, make sure that you have good magnesium level, calcium, magnesium, zinc, you have good, well supplemented, just to compensate for the effect of lipedema on the muscle. Now to answer, will liposuction also help with that? Potentially yes. Again, do we have data to say, oh yes, that's the treatment? No, we don't. But again, listening to our patients, they tend to feel better. They tend to improve. Time will tell us. I think after like 5 years, 10 years, I mean, that's all what we do here. We do lipedema, that's all our practice. We do 1 surgery per day. And we kind of follow our patients. We know exactly what's happening. And our experience has so far, we used to say a lot of the answers that I have now, I used to say most likely. Now I'm like, that's how it's going to be. Just because time has proved like what, you know, we know better than what we used to know 5 years ago. And I think 5 years from now, probably the answer to your question, instead of me saying now, most likely, probably not so sure, probably I'll be telling you, yep, 100%. But I can't say it now because we need time, we need more patients to do those procedures on, and then to really have data behind it. Say, okay, well, actually, out of 1,000 patients that we've done, we have 2% of people have that. It used to be 12%, it went down from 12% to 2%. Now we can say, well, actually it drops it by that much. So that's kind of, I love data, I love numbers, and I think without having data and numbers, we cannot evolve in what we do, especially in anything in life, but especially in medicine. Katie is asking, what's the price for, go to link in bio, fill your kind of like paperwork, and then at the end it will tell you kind of like a range of what we would charge for those procedures. Again, I get that, you know, for pricing and stuff, we get asked that a lot, and kind of like, you know, how come for the people who want like discounted prices, cheap prices, like, you know, bargain, stuff like that, we're not the practice for that. We are about high quality, great outcome, great experience, consistent results. We only do 1 procedure per day. We're like very unique practice. Let's say we're probably the only practice in the world who only does 1 surgery per day. We just don't do anything for lipedema. So we're very selective in terms of who you choose. Why do we do it this way? Why not do like 2 cases, 3 cases, 4 cases? Why not do insurance, open 2 rooms, do all that? We can, but then the quality will go down. And to me, it's about quality of outcome, quality of the product, and the quality of the customer experience. That's how I look at it. Marvel is saying, what do you think about fat grafting on lipedema patients? Do you think it's okay to do it? I'm not a big fan of fat grafting in lipedema patients. Again, no data for that, but if you truly think about it, we know lipedema fat is a diseased fat, right? Let's say somebody takes it, fat grafts it to the face, and now patients have somehow overgrowth reaction. You go through stress, GYN surgery, something happens, and now those fat are responding to hormonal changes, right? And now they're overgrowing. Somebody put like fat in the lower eyelid, now this fat is overreacting, is growing. That's a disaster. How are you gonna fix that? Cut the skin, take the fat out, and now you have the huge contour irregularities. I would just like stay away from it. I mean, if you have lipedema, just get rid of the fat. Now, don't have lipedema, you want to do facial fat grafting, that's fine, other stuff. But with lipedema fat, you gotta think long term. We don't know what's gonna happen to the fat long term in the body. It needs to be removed. You've got the tenderness that comes with it. We know for the fact it's thicker, fibrous, nodular fat, different than regular fat, which is mushy, yellow, kind of. The regular fat, it's mushy and yellow. You put it on the face or other area, it's gonna blend in easily. Lipedema fat, it's like small pebbles, it's like rocks, small pebbles of rocks. You put it in that, I mean, you put your skin, your hand, you're gonna feel it, you know? So I would be very cautious, you know, like, and unfortunately, if a surgeon, they might be amazing in fat grafting, but if they don't have much experience with lipedema, they might not know how the lipedema fat cells are. So I would be very careful. If somebody is willing to do that for you, I would ask the questions like, how many patients who have lipedema, you've done fat grafting on them, and what's the longevity since you've done it till now, and are they currently having any issues from it? And I think that's an important number, because if they tell you, oh, we've done like 1,000 patients with lipedema, we've done fat grafting, they did great, no issues. I think that's great. I think they should publish that paper, because I honestly don't think so. I think that that's a risk of transferring lipedema fat cells. They tell you we've done it 1 or 2 times, or we haven't done it, or yeah, maybe, then I would be very careful, because you don't want to be that first person who get that, and because it's a disaster. Like you get that, it's a really disaster to treat those cases. And sometimes, you know, certain things that you can't fix, but so other things you can fix, but not really. You can improve it a little bit, but you cannot like give an amazing outcome. So you gotta be careful not to mess up with it. So if that was a family member, I tell them just, it's not worth it. There's other better ways of doing it. All right, Lovewell54 is asking, if a woman practices conservative measures and does not gain weight, will the disease progress over time? Good question. I think by doing those 2 things, conservative and keeping your weight at bay, your chances of progression is much less, but it's not 0. So let's say if you don't do anything, people gain weight, they don't care, the chances of progression are here. If they do what you're doing, your chances are here. If you do what you're doing and you do LippyLipo, your chances are here. So basically, with everything you do, you add to it. You improve the chances. Because what happens is, we know lipedema is hormonal. Not only, it gets worse with, you know, with diet and kind of like menopause on it, but when like stress, menopause, pregnancy, the residual lipedema fat cells are going to progress. Even though if you're starving them by good diet and by MLD, they would progress. They would not progress at somebody who doesn't care, they're eating whatever and that. Those patients, they would progress much more. But in your case, you might be lucky and not progress, but also there might be a chance they might progress. I would say, if you don't have the resources or you're not interested in surgery, keep a very close eye on it. And if you feel like any changes, I would just treat it before it progresses. Again, the typically what we see by seeing tons of patients is usually lipedema does like that. Does slowly progress, and then over a short period of time, it goes up, it progresses, and then it stabilizes. It's like growth spurts, what happens in kids. That's my experience with lipedema. Like, tends to do well, and then patients like, oh my God, like all the past year or 2 years, I don't know what happened. Suddenly, boom, and then they plateau, and then boom, and then they plateau, and then kind of like it grows in spurts based on the hormonal changes. Ratna is saying, is it possible to handle this disease with massage or physiotherapy? I think we just answered this question here. I'm gonna save the live, so if you want to go back to the Q&As on the feed, and then you can hear the answer to this question. I'm sorry guys, I'm losing my voice, I don't know why. Laura is saying, what do you recommend for someone who lives out of state and would be traveling to have the surgery? And most of our patients, they fly to us. I'd say 99% of patients, they fly to us here. So it's kind of like we have a system. So just check with Jerry, and then she'll tell you basically what we need to do. They'll come here, you'll get the surgery. Most of patients, we do them kind of like, if the blood level is above 14, we'll do them the same week. So do one on Tuesday and one on Thursday. Give them 1 day for them to recover, and kind of for the body to absorb all the numbing medicine. And then usually do lower legs on Tuesday, and then the thighs on Thursday. And then they fly back on Saturday. That's typical. Unless they're flying from overseas, cross Atlantic, then we tell them to stay at least 3 days here. Just so that, because it's a long flight cross Atlantic, so that they're minimizing chances of issues. Claudia is saying, why is the maximum amount of fat taking out at one time is 5 liters? I know that in Europe they take out 8-10 liters. Is it safety concern? That's a great question. I mean, even in the US, you can go more than 5 liters, depending on the state, depending where you're having the surgery done. You can go to a academic center, big hospital. They can do some of them do 12, 15, 18 liters in one session. They do keep the patient overnight. Sometimes they send them to the intensive care unit because of fluid shift, or if the blood drops down. So the way I look at it is, when you go above 5 liters, it's like you're on the highway driving above 65 or 70 miles an hour, right? So this is where the 5 liter is. If you're below that, God forbid somebody you got hit by something, by a car, and that, you would have damage, but the risk of death is very low, right? Because you're not at high speed. If you're taking out 18 liters in one session, it's like driving at 180 miles an hour on the highway. Very simple thing can cause a crash and fatality. So it's really a risk. It's a risk and reward game. So how much of a risk are the surgeon, the hospital, the patient is willing to take? And that's really the answer. The way I look at it, if that was my wife, my daughter, a family member, I don't want to risk it. I just want to be safe. I want to do it. It's an easy surgery. It's a simple surgery. It's done as outpatients, done fully awake. I do it. I follow those lines. I can guarantee consistent outcome. Okay? I mean, that's kind of like that. Can you push it and do the others? You can, but now you're kind of playing with fire. Because let's say if the heart is not as strong as we thought with this, to get 18 liters out, or 8 liters out, or 10 liters out, we're going to inject probably 15 liters of fluid. Now 15 in, 10 out, you're talking about 25 liters shift in the body within 2 to 3 hours. You're under general anesthesia to do that much volume. Already general anesthesia increase the risk of complication. High volume liposuction increase the risk of complication. You're starting from a low blood count, increase the risk of transfusion. And now suddenly you go from a surgery that should be easier and simpler, and you take that risk to put it that much. The skin is not going to do well because suddenly you deflated all that at once. Your recovery is going to be horrible because you take all that under general anesthesia. You're going to be in pain. You're going to be weak. You're going to be in the hospital. And it's just in my opinion, it's not smart. Because why take that risk if there's a better way of doing it? It's kind of it's a person. Now, some people, their insurance doesn't approve. Some people don't have the resources. Some surgeons, they just don't have the capability to do awake, or they don't have the skills, or the hospital doesn't allow them to give them an entire operating room for the full day to do one case. Then the numbers won't work. There's many reasons why people do certain things, or they don't know how to do it. So there's multiple things. But knowing what we know now, it's really, when you think about it, it's common sense. It really is. There is a way you can do it fully awake, no general anesthesia, no IV sedation, nothing. You're walking, you're talking, you're like FaceTiming, you're calling your friends during it. You see exactly your outcome, you're moving the muscles, you're walking out, your recovery is easy, you have a pulse on everything that's going on. It's in your hand. Versus something you have no idea. The complication rate is so high, and it's just like, it's just not that I can talk forever about, what's the downside, but it's just not worth it. It's really not. And I want to be also politically correct, because I don't want like people to feel, of course he's saying that because like that's what he does and that. But it's in all reality, it's like when I go to those talks and see like, there'll be like sessions about complications and this and that, it's always the same thing. Because I'll be like, excuse me, and my first question is like, how was the surgery done? How many liters? It's all the same thing. General anesthesia, sedation, 12 liters taken out. And then boom, 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 boom. I can tell you the complications that comes with it. So, skin loss, skin necrosis, there's so many things that come over resection, under resection, discoloration of the skin. That's like a list of stuff. I don't want to discourage people or kind of scare people, but that's the point of these lives. You have to know kind of like, the pros and cons. I wish we'll have people, we'll have data where, and no one is going to publish that. No one's going to go say, hey, listen, we do it this under general anesthesia, and this is much our transfusion rate, this is how much our complication, this is how much this, and this is better than that. It's not going to get published because most of it is being done, most publications and research is done in academic centers. In academic centers, that's how they do it. So they're also going to be very careful about, they look at awake, it's like sketchy, like, oh, you're doing it awake, you're like, I don't know about that. And it's just kind of like, because they're behind, with all honesty. They're not like at that level yet. They're at level in research, there's so many things that way be in front of private practice in terms of stuff, but we have the advantage of that's all what we do. We don't have the hospital on top of us. We have the OR all day, every day. No one is behind us. There's no emergency that's gonna come. No one is pushing us back. So that's we have the luxury of doing a very, very high quality product. And that's kind of like what it is. And a lot of my amazing friends are like, chairmen in hospitals, some of them are CEOs of hospitals, and we talk about that all the time. It's just kind of like we are privileged to be in what we're able to do for our patients, and they are helping a lot of patients, and not everybody's going to be able to afford us. Truly, that's reality. But we need to help those patients as well. So but at the same time, we need to make sure that they are being helped in a safe way, in a safe manner. Lovewell is saying, but as your hormones ebb over time, won't the lipedema stop progressing in a woman's 70s or 80s? Good question. Who knows? The problem is by 70 or 80, depending on what stage. If somebody is stage 4 at 70 or 80, the problem is not going to be lipedema. The problem is going to be all the problems resulting from lipedema. They can't walk because of the heaviness of the lipedema, knee replacement, joint replacement, debilitating pain and that. So if you're 70 and 80 and you're stage 1, you're good. You don't need anything. I'm with you. But if you're 20 and you're stage 1, don't wait till 70 and 80, because when you're 70 and 80, you're going to be probably stage 3 or 4. And you're going to have so many other issues, and you're not going to be able to have it done. So to answer your question, if you're 70 and 80 and you're stage 1, enjoy life. You don't need to do anything, because your lipedema probably has progressed the most it's going to progress. But if you're 30, 40 and you're stage 2, 3, you want to do it. You don't want to wait till 70 and 80, because your quality of life is not going to be good at that point with stage 2, 3 lipedema. That night saying, okay, thanks, because I just joined this live, so didn't hear your explanation before. Oh, no problem, no worries. That's what I'm here for. Party is saying, I just arrived. Is the patient asleep during the surgery? Great question. Our patients, they're not asleep, no general anesthesia, no IV sedation, no PO sedation. It's just like us talking now. It's local, it's tumescent local anesthesia. Basically, it's like being at a dentist. We just numb the area and we do what we need to do. So all this was done fully awake. Patients was on the phone, FaceTiming, texting and calling her friends and significant others. So they're fully awake. Ratna saying, which doctor should I go to check my body from this? I live in Germany, I think. It's if you want to go to our live Q&A that we've had before, truly, if you do like probably 5 of them, sit and just do them, you're going to know if you have it. You really don't, you can go and spend time and all that to get 100%. But if you do the lives, I promise you, you're like 95% chance you're going to know if you have it or not. And if you still have questions, then take it to the next level. And for us, another question we get asked is, do I need diagnosis to come for you for LippyLipo? You don't. Truly, you don't. There's a lot of things out there where like, oh, you gotta get diagnosis, and then you have to go to your primary care, and you have to prove this, and then you have to prove that, and all that, like 6 months, 12 months of stuff. Now the lipedema has advanced. Just don't need that. Look at the pictures, look at your symptoms, you're gonna know. And then you get it done. And then you kind of like attack it before we give it the chance for the lipedema to progress. Marlena is saying, I did liposuction, but I feel that this kind of surgery has to be done throughout the whole leg, from thigh to ankle, not only on the spot. What is your opinion? Absolutely. But that's, again, the main difference with LippyLipo and regular liposuction. LippyLipo, you're doing 360 lipo all the way down, from the thighs all the way down to the ankles, whether 1 sessions or 3 or 4 sessions, but you gotta do it 360 degree. Regular lipo, you do patchy work. Patchy work with lipedema doesn't work. That's how people get contour irregularities. Most of the surgeons, probably if you had regular liposuction, I probably can tell you what happened to you. Most likely what happened to you is this. Don't ask me how I know, because we get a lot of patients, kind of the same thing. Regular lipo, they go to somebody who does liposuction, great plastic surgeon, they do liposuction here, they might do liposuction to the inner thigh, and that's usually the case, maybe a little bit to the anterior thigh, and that's it. Patient comes to us, now she has contour irregularity here, and then she has contour irregularity here. You see kind of the step-off deformity. Nothing was done to the back of the leg, nothing was done to the front of the leg. And no one's touching that ankles and that. And patient's not happy. She goes back to the surgeon and they say, I can't believe you're not happy, you look great. Because to them, that's the best they can do. And to them, they look great because that's, in their opinion, this is the best outcome that patient can get. But then when they come to us and see this, they're like, this is what I want. To get that, you need to get through LippyLipo. And that's kind of like, that's the problem. Now, and it's not the patient's fault and it's not the surgeon's fault. The surgeons don't know any better. They were never taught that in school. They really don't know. You don't know what you don't know. So they don't know any better. And the patients, they don't know any better. They don't know. They're the patient. How would they know? But then when they come on their lives, now they're able to connect all the dots. So I promise you, I might be botching your name, Marilena, but that's probably what you have done, if you're at that area. Danny is saying, do you operate in other countries? I don't. I just operate here. Fima is saying, why is it so expensive? I think it's actually very, very... So we do only 1 procedure per day, and we're consistent in our results. So actually, if we want to go down the route of like insurance and doing many cases, it's much more profitable that way, because you do so many cases, but you cannot give the outcome. So we're actually, in a way, from a model standpoint, it's actually hurting us. When we switch here, we got hurt, but it's the right thing to do for the patient. No question about it. So it's no different than flying private or flying first class or flying or taking the car or taking the bus. It's kind of which modalities you want to have, and different people, they want to have different things. So this is kind of like, this is where we are. Our prices consistently go up, and that's kind of like how just to be able to provide the outcome we can. Because what happens is, over time, is you can say, hey, you know what, why don't you drop it and do 2 cases a day? right? And you still like the sum will be better. Who's gonna pay the price? The patient, because they're not gonna get these outcomes. When it's taking 6 hours with microcannula and like 5,000 of that, like literally finish the case, like I'm sweating, right? The patient means just like all the emotions are in there. Imagine finish that and then do it again. You're not gonna give it all your heart, all the energy to get, because now it's like 12 hours into 2 surgeries. It just doesn't work to provide this best outcome possible. And that's why we don't do it that way. That's why we just, to us, quality. Quality is over everything else, over quantity, over numbers, over discounts, over prices, over this, over that. We're just not interested in dropping our quality. Claudia is asking, when a person is pre-diabetic with a flat tummy but having lipedema in legs, can liposuction help also with getting diabetes? You know, that's a great question. I don't know. Could it help with diabetes? Potentially. You know what? We're going to go live with Dr. Bika in the next, I think it's going to be January 13th. I think so. That would be a great question for her. If you don't mind, kind of join us and let's ask her this question, because it's more of endocrinology and lipedema and kind of that. Hopefully it does. I really don't know. And I think that would be a great question for her. I'd actually write it down and ask her. Very good question. A lot of question about price. You guys go on the link in bio and you can check that out. After the procedures, what are the chances of recurring? Again, in our hands, it's less than 1%. Very low chances. But again, in our hands. I feel a lot of recurrence or overgrowth is actually people haven't got to the sweet spot of liposuction. People are under-treating those patients. They call it recurrence, in my opinion, because we just don't see it. It's very rare to see recurrence overgrowth. Once we treat an area, it's treated. Very low chances of recurrence after treating one area. Now, if we haven't treated the arms and patients are having a flare, the arms might flare, but it doesn't mean it's over recurrence or it grew to the arms. It's just patients are born with a type 4 where they had it in their arms. And since the legs are treated, it's not going to flare in the legs, it's going to flare in the area where you have lipedema. Papani is asking, I feel I'm botching your name, guys. I'm very sorry about that, but okay, I'll say Maria. Answer with Maria. How long does it take for the full recovery and the final aesthetic results? Thank you from Greece. That's awesome. I mean, let me show you here, Maria. This is at 1 week. I mean, at 1 month. Before, after that 1 month. So some people, like in a month, you already have more 80% of the results. But really, the answer is, let me see if I have a front picture on her. The answer is probably 6 months to a year to really get like the final outcome, to see kind of what she is. This is her at like 1 month. So again, like really good shape, even so early on. Okay, let's. Mandy is asking about pricing. Same pricing. I'll have you go to the link in bio. Laura is asking, once the liposuction is done, what happens to the excess skin? Take a look. Her skin looks great. A lot of questions, a lot of people ask like, oh, do you do laser, J-plasma, heated device, cooling device, this, that? You don't need it. If you do a great job with LippyLipo, you do great work, all the other stuff actually adds to the complication of the surgery. From heat burns, skin loss, skin necrosis, fibrosis, scar tissue, extra cost for no reason. One thing you have to understand as a patient is there's a lot of things out there, just marketing tools for people to just make extra money, unfortunately. It doesn't mean that the surgeon is lying about it. It means that the surgeon is convinced that that helps the patient. Because when people come to us, like, how are you getting all these results without doing any of these, you know, whatever you want to name it, Vaser, laser, I mean, there's so, if you look at history, when I look back at history, there's so many names and so many machines and so many things that just don't exist anymore. How, if they work so well, if they are like giving amazing results, how come they don't exist? Because they were a fad. They just didn't work. But people were selling it, they were making money off it, and it was like they thought it was working. And I'm not saying that to say everyone's using them, they are lying to the patient. I truly believe that, with all honesty, I truly believe that the physician is doing what they think is the best for the patient. But they don't know what they don't know. There's a lot of marketing, no different than, I don't want to say names, but there's so many devices, the non-surgical devices. Oh, you do this, you're gonna get that, and this and that. And it's just like, if you go over history, there's so many names of devices, they just don't exist anymore. If they were so good, why they don't exist? I would love to kind of sit in my office, sip some espresso and enjoy it, and put the machine and let the machine take this patient from here to here. Wouldn't that be amazing for everyone? It would be the best thing ever. I'll be the first one to use it. But it's too good to be true. It doesn't work. I actually see the reverse. I've seen patients doing non-surgical. They come to me, they have something called PAH, paradoxical adipose hyperplasia. Means overgrowth of the fat cells because of non-surgical treatment of those pads and stuff that they put on the skin. And now it's a harder tissue, it's fibrotic scar tissue that makes it harder to get a good, nice, smooth control. The surgery is longer, more painful to the patient. And it's just the patient didn't know, the esthetician or the physicians didn't know the kind of what the result's gonna be. And then 3, 4, 5 years, 6 years, and then guess what? Something else comes on the market. And now no one's talking about the past, and now people say, oh, look at this beautiful pen, it's awesome, it does great. And then they sell a bunch of it, and then 4 or 5 years later, the same thing. Doesn't work, gets stuff, and then something else goes in. And then the patients are being abused, and the physicians. A lot of physicians believe, a lot of physicians, they get on, because they don't know, right? They believe it, especially if they are new out of residency. They're like, oh my God, that thing, and then they try it. Now they paid $500,000 for it. They think it works. They try it for 2, 3, 4 years. Then they realize a lot of complaints from patients, a lot of complications. It doesn't work, and now it sits in a corner in the practice. Again, don't ask me how I know, because I've done it. I've been there many times where I believed, I trusted. You got the machines, you've got the stuff, and I have probably 2 rooms full of lasers and stuff that just don't work. They just they didn't deliver on the promise. The promise is great, the idea is great, but it's just not there. It's just so much marketing, and then so much people are believing in it, and then it becomes not real. And then when you find out, now you have a bunch of patients who are not happy about it, right? And they should be not happy because they were promised something, they didn't get it, and that becomes because think about it, if I was let's say I'm doing whatever on this patient, let's say if I did on her, I don't want to say names because I don't want to attack anyone. I think they're all kind of the same. If I did this device on her, and you know what, and I'm look, she looks great, right? But for that device, we're gonna charge $10,000 more, all right? I actually didn't use anything. I didn't. I just did LippyLipo, and I got her from. Her skin looks awesome. But now I can say, oh yeah, I used that device to get her from here to here. And now suddenly that device has value. She goes to somebody else who are using that device, they don't get this outcome. Then what do you do? The thing is, it's not the brush, it's the painter, it's the person doing it. How good they are, how meticulous they are, how long it's just those stuff that doesn't work. That's my thought on it. Anyhow, Party is saying on that patient, how many liters were removed? 1.6. Good question. Common mistake to go to 5 liters on this one. With 1.6, look how awesome she looks. Look at her back. Pictures. 1.6 liters. Imagine, look how, and this is only 1 month. With swelling, bruising, all that stuff, at 1 month, look, 1.6 liters. Imagine if I took out 5 liters on her. Disaster. She would look like skin grafts, contour irregularities, all that stuff. The key is not it's like the machine. It's not how many liters. Low stages for patients, don't fixate on liters. You get in trouble by fixating on liters. You get the surgeon in trouble by fixating on liters, especially somebody who's not experienced. They're focusing on the 5 liters, they keep on going, and then it's a disaster. You cannot fix it. Because when you gotta leave a nice thin layer of fat between the skin and the muscle to get this beautiful shape. You take that out, then it becomes a skin graft. It's called skin adhere to the muscle. It's a disaster. It looks horrible. And you cannot fix it. Now you have to move fat to the area between the muscle and the skin. You still have the contour irregularities. The veins open up and the blood vessels and that skin graft because so it survives. I mean, it's just, and I've seen those disasters from other physicians. It's like, I'm like, man, I just can't help you. Like that patient, next time call me before you do the surgery because I can tell you, oh, on her, don't take more than 1.5 or 1.4. I'm not going to push them to 1.6 because I know they're going to overdo it. And I know they're not going to use microcannula. I know they're not going to spend 6 hours to do her case. Because they have 4 cases to do. They're probably going to do her in 2 hours under general anesthesia and then in and out. So I'm like, to be safe, I protect them. It's like, do 1.2 liters so that they don't mess her up. But it goes back. It's not the number. It's not the technique. It's the person doing it, how consistent they are in providing the outcome that you're looking for. Ratna saying, thank you for the explanation. You're welcome. Daki is saying, do you do it just for treatment or for cosmetic? For both, functional and cosmetics. Because you don't wanna just leave the function and give a bad cosmetic result. Because now you take one problem, you switch one problem to another problem. But also you don't wanna just do cosmetic. You wanna really improve both. Because lipedema is problem in both. Cosmetic and pain, functional. You want to improve both. Otherwise, you don't want to improve only 50% of it. Deco is saying, for stage 3-4, does the patient needs compression, soaks compression? Yeah, absolutely. Any stage, 1, 2, 3, or 4, any stages of lipedema, you gotta be on compression. Especially after procedure. Yusa is saying, can just women get lipedema or can also men develop it? You know, I haven't seen it in men. I'd say 99% are women. But again, it's medicine. You might find somebody who has it, but 99% plus are women, and it's hormonal. Man can have the gene, but it doesn't get expressed in men. The gene gets expressed in women. Verti is saying, do you use wall procedure? I don't. I use tumescent liposuction. Again, we were just talking about that. Is this wall, pall, tall. People get, like, even me when I started, like, there's so many things. Wall, pall, tall, laser, vasal, J-plasma, this, that. There's like 20 different techniques. Dry lipo, wet lipo, super wet lipo, tumescent lipo. I mean, it's so confusing, right? For many people. It's not the technique. Make sure you connect to your surgeon. Make sure your legs, what he has done, is the outcome that you're looking for. And make sure they've done hundreds and hundreds and hundreds of these. And make sure that's all what they do. And if they do only one a day, it's even better. And if that fits that box, call it like procedure box, then you want to go with that surgeon. Otherwise, run away. Because you know what? You can have somebody who does whatever, say, hey, I do wall, or I do tall, it means nothing. All that stuff, they mean nothing. But to help people out, especially surgeons, they ask me like the technicality. I use tumescent, TAL, tumescent assistant local anesthesia, and just local. We don't do IV sedation, we don't do PO sedation, we don't do general anesthesia, because I feel it increases the complication of the surgery for no reason. And that allows me to, for the patient during the, it's like, tighten the muscle, relax the muscle, move this, move that, do that, go on your side, flip on your stomach, flip on your back. They're fully awake, they're kind of like talking. It allows you to give them a better cosmetic outcome. And the relationship, the patient-doctor relationship is better. Because they know every step. Hey, boom, 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 we're doing this. Hey, how are you feeling? This, that, that. We're back and forth. So in a way, the patient's doing the procedure with me. So they know exactly how things are going. At the end, I'm taking pictures, videos, like, hey, take a look here, boom, 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 this is your before. This, like this patient here, on table, I showed her that as we were doing it. I was like, hey, listen, before I was like, hey, take a look. And you was like, oh my God, they look great. You know, I have normal legs. I'm like, great, awesome. You're good with it? Yeah, I'm good. Okay, now let's do the back. Kind of like, but you gotta do it this way. Now the patient is part of the procedure. Versus I go, take 5 liters out, it's a mess, patient is there. The first time she sees her leg is like 2 weeks afterwards. They're swollen. She has no idea what they look like. And then, oh, wait until you get the outcome. It comes 6 months. Oh, you're not at your final outcome. It's going to get better. Wait like 6 more months. It's, guys, do your homework. Go to the right person. Make it easy on you. Okay. Let's keep on going here. Brandy, hey Brandy, I struggle with swelling when I fly. Will this procedure help stop that? Good question. I hope it does. the most likely it will. Will it totally take it out? Probably not. It really depends. Stage 1, it's going to help them from swelling more than somebody with stage 4. Some people who don't have lipedema, they swell on the airplane. So it really has to see, it's a spectrum. Hopefully it will make it less, but you can't say it might help it, it might stop it. I doubt it. I don't think it will stop it. Could it help it? Most likely yes. And that's you have to see how the body reacts, the age of the person, the tissue characteristics, and what stage they are. Verit USA is saying, my legs are so bad, I would trade them in for these patients before photos. I'm 50. I mean, that's great. You know, like, if that patient, you know, probably when you were 20, they were looking better than they are looking now at 50. And that's why I tell people, like, guys, don't wait. Don't wait till 50, 70, 80, 60. It's going to only get worse with time. Treat it early on. Early treatment is key. It's so confusing. You're right. Thank you. You're welcome. Claudia saying, I'm very interested in being awake surgery you're offering. Is it totally pain-free? Do your patients get anxiety meds? No anxiety meds, and it's not like totally pain-free. I mean, it's like being at a dentist in a way. Like, you're going to feel the numbing every now here and there. Different people are different depending on kind of how well they feel it. But I would say about 80 to 90% of patients, they say that pain is like 2/10. And then you have the rest, the 10% left of patients, 5% of them, they don't feel anything the entire case. They're like, oh, you know, like really nothing. I'm like, you're not even human. And then you have 5%, they are oversensitive. So we take the time, we change cannula, we use this, that, so that we can get them through the numbing. Once they are numb, they don't feel anything after that. Cherry is saying, I'm stage 2, your office gave me a code for 30,000 each leg. Is this correct? Not sure if it's each leg. These are our prices usually on average for both legs. But again, it depends. Maybe in your case, it's very complicated and it could be for each leg. Good question. Crystal is saying, okay, she's trying to join in. Trying to make sure that I answered all the questions here. Awake, that's another patient interested in the Awake. Guys, Awake has been a game changer. I used to do those cases under general anesthesia. But when I shifted to Awake, it was a big game changer. Because under general anesthesia, we would wheel the patients to the car, they are on a wheelchair, they're tired, they come the next day, they needed fluids, this, that. I mean, it's just like, the recovery was horrible the first week. When I started Awake, I'm like, oh my God, they're just walking to the car, they're doing all that stuff. I'm like, it's been like a game changer. So by far, I would like, Awake is the way to go for lipedema. No question about it. Anyhow, guys, I gotta go here. Every Monday, if you have other questions, every Monday at 12 p.m. Central Time, gonna come here, get your questions, anything related to lipedema, and answer that. Here from Zichetsky. I'm up next week. Can't wait to see you in person, doctor. I'm so excited for you. You're awesome. You've been on most of these lives, and I can't wait to meet you in person. And you're gonna do great. Most people get anxious about it beforehand. Don't worry about it. You're gonna do awesome. It's okay to be anxious. It's just part of the process. Once I see you in the morning, we'll do the ultrasound, we'll take measurements, and then we'll get you back, and then you're gonna feel awake, you and I will be talking, and by the end of it, you're gonna be like, okay, that wasn't too bad. So I'm excited for next week, and we'll see you guys next Monday.